Hello everyone, and welcome to today's lecture. This video is intended for the 4th year level interns of Southwestern University FINMA. My name is Lessa, and I'll be guiding you through this topic today. For this lecture, we will be discussing about renal diseases. Before we start, please turn to page 61 of your CM compilation manual. Please also prepare your pens and your additional extra papers or sticky notes or your highlighters if you want to be guided as we go along the way. So let us start. So first is about your renal disease. So here, renal disease is classified as being first glomerular, next is tubular, and the third one is your interstitial. So kani siya is depende sa kung asa na area sa kidney ang affected. Let us first start with your glomerular disorders. Usually, your glomerular disorders result from immunologic disorders. For instance, ang mga immune complexes form from immunologic reactions or di ba taas ang serum immunoglobulins like IgA, and kani sila will circulate in the bloodstream and dito ma-deposited sa atoang glomerular membranes. So aside from immunologic disorders, again, mao ni siya ang most common. Aside from that, we also have your non-immunologic causes. Non-immunologic causes. So for our non-immunologic causes, we have your exposure to chemicals and toxins. Next, disruption of membrane charges as seen in our nephrotic syndrome. Maagian ta na later. Next is your deposition of amyloid material from systemic disorders. And lastly, we have basement membrane thickening. So this is seen in our diabetic nephropathy. So the term glomerulonephritis refers to a sterile, inflammatory process that affects the glomerulus and is associated with the finding of blood, protein, and casts in the urine. There are different types of glomerulonephritis in which we will be discussing later. So arisat as the first one, which is your acute glomerulonephritis, AGN, or ang other name ana sa iya is your acute post-streptococcal glomerulonephritis. So in this disease, there is a sudden onset of symptoms following respiratory infection caused by unsa man, that is your caused by your group A beta hemolytic strep. So if you can recall in your bacteriology, unsa niyang ato ang group A beta hemolytic strep, that is your S. pyogenes. So your group A beta hemolytic strep that contain the M protein, and the patients in here presents with fever, edema, hypertension, oliguria, and hematuria. So unsa day nahitabo ani ato ang acute post-streptococcal glomerulonephritis. So the nephrogenic strains of the streptococci mo form sila og immune complexes with their circulating antibodies, and this one will become deposited onto your glomerular membrane. So mao na siya ang nahitabo sa ato ang acute glomerulonephritis. So the presence of your anti-streptolysin O or ASO provides evidence that the disease is of streptococcal origin. So since the development of our rapid anti-group A streptococcal enzyme test, the incidence of our acute glomerulonephritis has declined. So let us go now to the next disorder, that is your rapidly progressive crescentic glomerulonephritis. So ang kanisiya is a more serious form of acute glomerular disease. Aside from that, it has a poorer prognosis. And this often terminate to renal failure. So mas lala siya compared sa ato ang acute glomerulonephritis. This one is often a complication of immune systemic disorder, which is your SLE or our systemic lupus erythematosus with macrophages in the basement membrane. So unsa day nahitabo ani niya? So in here magbutang sa taog normal capillary. So ang atong normal capillary kay i-damage siya sa ato ang macrophage or i-attack siya sa ato ang macrophages. Next, tungod ana unsay mahitabo, it will cause leakage of plasma and cells into Bowman's spaces. After ana, unsa may mahitabo, mo form siya og crescentic lesions. Mo nang ginatawag pud ni siya og crescentic glomerulonephritis. So unsa may naaani ato ang crescentic lesions, it is filled with your macrophages, fibroblasts, and your fibrin. So after that, this will cause the damage to your capillary tufts. So again, ato asyang balikon. Ang atong macrophages will damage your capillary walls, causing leakage of cells and plasma into your Bowman spaces. So crescentic formation filled with your macrophages, fibroblasts, and fibrin forms in your Bowman space. So this one results in permanent damage to capillary tufts. So your rapidly progressive glomerulonephritis has rapid onset with progressive renal failure. So ang iyahang primary urinalysis findings are your microscopic hematuria, red cell cast, and proteinuria. So this one will become more abnormal as the disease progresses. Another significant finding, we have your increased BUN and your creatinine. So that's it for our rapidly progressive crescentic glomerulonephritis. Next one, unsa man ni diri? Let us write good pasture syndrome. In your good pasture syndrome, a cytotoxic antibody can appear against the glomerular and alveolar membranes after viral respiratory infection. So this follows after a viral respiratory infection. So attachment of your anti-glomerular basement membrane autoantibody to the basement membrane, followed by complement activation, produces the capillary destruction. So at first, ang initial complaints ani or atong initial pulmonary complaints ani niya is your hemoptysis and dyspnea, and followed by your development of hematuria. So the primary urinalysis findings of your good pasture syndrome is your proteinuria, hematuria, and red cell cast. So very important or very significant findings sa ato ang good pasture syndrome is again our anti-glomerular basement membrane antibody. Aside from that, progression to chronic glomerulonephritis and end-stage renal failure is common anemia. So let's now proceed to the next disease, that is your, so let us write here, that is our Wegener's granulomatosis. So your Wegener's granulomatosis is a granuloma producing inflammation of the small vessels, mo na ginatawag siya granulomatosis. Granuloma producing inflammation of small vessels, primarily of the kidney and your respiratory system. So at first, patient usually present with pulmonary symptom, mao ang mag-una, and develop later on the renal involvement. Primary urinalysis finding for Wegener's granulomatosis is hematuria, proteinuria, and RBC casts. So, a very significant finding for our Wegener's granulomatosis is your ANCA, or that is our anti-neutrophilic cytoplasmic antibody. Anti-neutrophilic cytoplasmic antibody. So, ganiha sa atong good pasture syndrome is anti-glomerular basement membrane antibody. Karon sa ato ang Wegener's granulomatosis, that is your anti-neutrophilic cytoplasmic antibody. We also have increased BUN and creatinine. So, testing for our ANCA or anti-neutrophilic cytoplasmic antibody involves the incubating of your patient's serum with either ethanol or formalin or formaldehyde. Formalin or formaldehyde. So in here, if neutrophils are fixed in ethanol, unsa ang iyahang pattern, it will form a perinuclear pattern. And this is called your P-ANCA. What about if neutrophils are fixed with formalin or formaldehyde? So your antibodies form a granular pattern. And this is called as your C-ANCA. So please remember that. Let us now proceed to our next disorder, that is your henoch-Schönlein purpura. So paki-change sa spelling, ani niya, make it this one. That is your henoch-Schönlein purpura. So purpura disease occurs primarily in children after upper respiratory infection. So initial symptoms include, let us write it here, raised red patches on the skin. So your respiratory as well as our gastrointestinal symptom may also be present. So respiratory symptom is na ay blood on sputum, and gastrointestinal symptom is na ay blood sa stool. And ang most serious complication ani niya is your renal involvement. So primary urinalysis result of your henoch-Schönlein purpura is your mild to heavy proteinuria, hematuria, and RBC casts. So next one, that is your IgA nephropathy. Or mauna, ang other name niya is Berger's disease. So basin gut munta if makahuna-huna taan ni pero dili. So our IgA nephropathy, it is the most common cause of glomerulonephritis. So i-write pod nato diri, it is the most common cause of glomerulonephritis. So immune complexes with IgA are deposited on the glomerular membrane. So in our IgA nephropathy, in here, taas ang serum IgA sa ato ang patients, which may be a result of your mucosal infection. So this is most frequently seen in children and young adults. Episodes of macroscopic hematuria following infection or strenuous exercise. So the primary urinalysis finding anemia is the presence of your hematuria. Let us now proceed to the next one. So next is our membranous glomerulonephritis. So in here, there is a, please write, pronounced thickening of glomerular basement membrane. So again, in our membranous glomerulonephritis, there is a pronounced thickening of glomerular basement membrane following deposition of IgG. So again, kaniha sa Berger's disease, taas ang serum IgA. Ang kaning sa ato ang membranous glomerulonephritis, ang deposition is your IgG. So please remember that. So it is associated with SLE. Aside from that, we also have Sjogren's syndrome. Aside from that is your syphilis, hepatitis B, gold and mercury treatments, and malignancy. So please ko remember ana nila. So the disease progress slowly with possible remission, and it has a tendency for thrombosis. The laboratory findings include microscopic hematuria and proteinuria that may reach concentrations similar to those in your nephrotic syndrome. So that's it for membranous glomerulonephritis. Next one is your membranoproliferative glomerulonephritis. So, ang kanisiya, your MPGN, is marked by two alterations in the cellularity of the glomerulus and peripheral capillaries. So, sa ato ang type 1, it is marked by increased cellularity in the subendothelial cells of the mesangium. Next, sa ato ang type 2, we have your dense deposits in the basement membrane. So your MPGN appears to be in association with autoimmune disorders, infections, and malignancies. So kadalasan sa patients kay children, and the disease has a poor prognosis. The primary urinalysis results are hematuria, proteinuria, and other significant finding is decreased serum complement. So in here, additional information, ang atuang type 1 patients progress to nephrotic syndrome. Ang atuang type 2 patients experience symptoms of chronic glomerulonephritis. Again, type 1 patients progress to nephrotic syndrome. Type 2 patients experience symptoms of chronic glomerulonephritis. Next one is we will be talking about chronic glomerulonephritis. So, depende sa amount and duration of damage sa glomerulus sa ato ang mga na-discuss na glomerular disorders ganina, progression to our chronic glomerulonephritis and end-stage renal disease may occur. So, in your chronic glomerulonephritis, there is marked decrease in renal function resulting from glomerular damage precipitated by other renal disorders. So there is a noticeable decrease sa ato ang renal function and progression to renal failure. The primary urinalysis result are hematuria, proteinuria, glucosuria, cellular and granular cast, waxy, and broadcast. So in here, naasad siya markedly decrease glomerular filtration rate is present in conjunction with increased BUN and creatinine levels, as well as electrolyte imbalance. So that's it for chronic glomerulonephritis. Next is your minimal change disease or your lipid nephrosis. Lipid nephrosis. So it produces a little cellular change in the glomerulus except for some damage to the podocytes and shield of negativity. So ang ato ang i-write diri sa etiology is the disruption of podocytes. So it occurs primarily in children following allergic reactions and immunization and possession of your human leukocyte antigen B12 or our HLA B12. So the primary urinalysis results are heavy proteinuria, transient hematuria, and fat droplets. Other significant findings, we have serum albumin, cholesterol, and your triglycerides. Next is focal segmental glomerulosclerosis or FSGS. In here, there are damage to podocytes which affects only certain areas of glomerular of your glomeruli, sorry. So mo nang ginatawag siya og segmental kay maka-affect ra siya sa certain numbers and areas of your glomeruli. So immune deposits, primarily IgM and your C3, are a frequent finding. So again, Berger's disease, IgA, membranous glomerulonephritis, IgG, focal segmental glomerulosclerosis, IgM, and C3. So it is seen in association with abuse of heroin. So please take note ani since nigawas na ni siya sa boards, analgesics, and with your AIDS. Symptoms may be similar to the nephrotic syndrome as well as our minimal change disease. The primary urinalysis findings are moderate to heavy proteinuria and microscopic hematuria. Next is nephrotic syndrome. So when you study, it is very important na kabalo jud na sa atoang nephrotic syndrome by heart because when you take the board exam, isa ni siya sa pinakamugawas. So let us write in here sa blank, that is your nephrotic syndrome. Nephrotic syndrome is marked by first, massive proteinuria or markedly elevated proteinuria, pwede sad na siya. So, it has greater than 3.5 grams per day. Imagine unsa kadaghan. Next is hypoalbuminemia. Next is hyperlipidemia. And lastly is your pronounced edema. So atong i-discuss later on kung giunsa ngano di ay magka-massive proteinuria, magka-hypoalbuminemia, magka-hyperlipidemia ug magka-edema si patient. So ang increased permeability sa glomerular membrane kay tungod ni siya sa first na damage ang shield of negativity, and ikaduha is podocytes that produce less tightly connected barrier. So this is not normal. So ang iya daw shield of negativity and ang podocytes kay less tightly connected siya. So if inana man gani unsa may mahitabo. So ang atoang mga high molecular weight proteins and lipids og atoang negatively charged protein, particularly si albumin kay makaagi na sila, maka-pass through, and once they pass through, they will be eliminated into the urine. So maunang there is massive proteinuria. So ang albumin, ang primary protein na ma-deplete sa blood causing your hypoalbuminemia. So this hypoalbuminemia appears to stimulate increased lipid production by the liver, so maunang taas pod ang serum lipids. That is why naapoy hyperlipidemia si patient. And in here, 'di ba, there is a depletion of your albumin or your plasma albumin. So tungod ana, mo lower ang oncotic pressure sa capillaries and increases fluid loss into the interstitial space, plus pa jud sa sodium retention, mo na siya ang makakos sa atoang edema. So mo na siya hitabo sa atong nephrotic syndrome. So the primary urinalysis findings of your nephrotic syndrome, you have your, please take note, heavy proteinuria, microscopic hematuria, renal tubular cells, oval fat bodies, fat droplets, fatty, and your waxy cast. So please remember and memorize or familiarize dyan na inyong mga primary urinalysis findings. Next one is we have our Alport syndrome. So your Alport syndrome is an inherited disorder of collagen production affecting the glomerular basement membrane. So it is a genetic disorder again showing lamellated and thinning glomerular basement membrane. There is a slow progression to nephrotic syndrome and end-stage renal disease. So during respiratory infection, males younger than 6 years may exhibit macroscopic hematuria and continue to exhibit microscopic hematuria. So naasad tay other abnormalities in hearing and vision that may also develop. So in here, please go change aning blood glucose for our other significant findings. Please change this one into genetic testing. So that's it. Now let us proceed to our tubular disorders. So here first, ang tubular disorder that we will be discussing is your acute tubular necrosis. So this is a primary disorder associated with damage to the renal tubules. So this damage to the renal tubular cells is caused by, let us write it here, ischemia or toxic agents. So the disorders causing ischemic, so let me erase it first. Atong pabagaon lang siya. So the disorders causing your ischemic acute tubular necrosis, please take note, they are our shock, trauma, and surgical procedures. What about the nephrotoxic agents that may cause our ATN? The nephrotoxic agents include aminoglycoside, we also have amphotericin B, aside from that is your cyclosporine. Next is your radiographic dye. And also our organic solvents. So the clinical course of your ATN is acute of renal dysfunction, usually resolved when underlying cause is corrected. The primary urinalysis result, you have your microscopic hematuria, proteinuria, renal tubular epithelial cells, RTE cast. So mo na atong timailhan if na tubular injury, if mataas na sila. And aside from that, we have your hyaline, granular, waxy, and broadcast. Other significant findings, we have your hemoglobin, hematocrit, and your cardiac enzymes. Next, let us write it in the blank, is your Fanconi syndrome. In your Fanconi syndrome is the disorder most frequently associated with tubular dysfunction. So it is a generalized failure of tubular reabsorption in your proximal convoluted tubule. So, in contrast sa ato ang renal glycosuria, ang kani siya, ang iyahang ma-affected ra is the reabsorption of glucose. On the other hand, sa atong Fanconi syndrome kay naapay lain aside sa atoang glucose. So the primary urinalysis finding is your glucosuria and as well as possible cysteine crystals. We also have serum and urine electrolytes and amino acid chromatography. Next is, I think wala ni siya sa inyong notes, so you can add this one. You may take a picture or diba i-stop sa ninyo ang kaning lecture. Then, inyong i-pause ninyo ang lecture and write this table in your notes. So, next is your diabetic nephropathy. So, this one is the, let us write it here, most common cause of end-stage renal disease. So again, ang ato ang diabetic nephropathy is the most common cause of your end-stage renal disease. Kinsa ganito ang ato ang most common cause of glomerulonephritis? That is your IgA nephropathy. So in here, the glomerular damage is believed to be associated with deposition of glycosylated proteins resulting from poorly controlled blood glucose levels. Again, it results from poorly controlled blood glucose levels. So the damage to the glomerular basement membrane occurs not only as a result of glomerular membrane thickening, but also because of the increased proliferation of mesangial cells and increased deposition of cellular and non-cellular material within the glomerular matrix, resulting in accumulation of solid substances around the capillary tufts. Primary urinalysis result, we have your hematuria, proteinuria, glucosuria, cellular and granular cast, waxy and broadcast. So, early monitoring of persons diagnosed with diabetes mellitus for the presence of microalbuminuria is important to detect the onset of diabetic nephropathy. So, other significant findings, we have your blood glucose. So, now we are on our interstitial disorders. So, considering the close proximity sa ato ang renal tubules o renal interstitium, disorders na mo-affect sa ato ang interstitium will also or may also affect the tubules. So, this result in the condition commonly called as your, let us write it here, your tubulointerstitial disease. So, mo na siya buot pasabot ana na term. So, in here, the most common renal disease is unsa man? Can you guess? The most common renal disease, makaingon jud ka na most common ni siya kay maupod ang frequently gyud ma-encounter. That is your UTI. So, infection may involve the lower urinary tract and upper urinary tract. So, your lower urinary tract, as may naaana, is your urethra and bladder. your upper urinary tract, or your pelvis, renal pelvis, tubules, and interstitium. So the most frequently encountered is canicia, infection of the bladder, that is your cystitis. So para di na to malimtan, isulat po na to diri, this is the most frequently encountered. So now let us talk about your cystitis. This is the ascending bacterial infection of the bladder. Ang iyahang clinical course is there is acute onset of urinary frequency, burning, and lower back pain resolved with antibiotics. So your urinalysis result or primary UA result, you have your leukocyturia, bacteriuria. So makaingon jud ka na UTI na siya if dapat naayod ang WBC o bacteria. Aside from that are microscopic hematuria, mild proteinuria, and increased pH. So now let us proceed to the next one. So acute pyelonephritis is the infection of upper urinary tract. Mo na siya ang ato ang ginatawag na pyelonephritis, infection of the upper urinary tract. Pwede ni siya acute, pwede ni siya chronic, which we be talking about later. Diri sa ta sa ato ang acute pyelonephritis. So this one most frequently occurs as a result of ascending movement of bacteria from a lower UTI into the renal tubules and interstitium. So infection of the renal tubules and interstitium is related to the interference of urine flow to the bladder, reflux of urine from the bladder, and untreated cystitis. So there is an acute onset of urinary frequency, burning, and lower back pain result with antibiotics. So with proper antibiotic therapy and removal of underlying conditions, acute pyelonephritis can be resolved without permanent damage to the tubules. So the primary UA result, you have your WBC, your bacteria, WBC cast, and bacterial cast. So naa diha sa notes kay naay granular, waxy, broadcast, so i-erase na siya. So ang ato ang cast kanong ato maning gina-mention karon. So ma-differentiate nato si upper o lower UTI with the presence of cast. So, di ba, your cast is unique to the kidney. So, between sa upper o lower urinary tract, asa man si kidney, of course, naa sa ato ang upper urinary tract. So, that's why, with the presence of WBC cast o ato ang bacterial cast, makaingon ka na pyelonephritis siya and not cystitis. So, isa na sa ilahang key differentiating factor. So gipa-erase ato nato ganiha si granular, waxy, and broadcast kay dili pa na siya related sa acute pyelonephritis. Ari na siya sa sunod. So next, we have your chronic pyelonephritis. So this is a serious disorder that can result in permanent damage to the renal tubules. So this is the recurrent infection of the renal tubules and interstitium in response to certain medication. It is frequently diagnosed in children, requires correction of the underlying structural defect, and there is a possible progression sa atoang renal failure. So sa atoang primary urine analysis result, pareha siya sa acute pyelonephritis na ay WBC, na ay bacteria, WBC cast, bacterial cast, hematuria, proteinuria. But as the disease progresses, a variety of granular, waxy, and broadcasts are present. If maka-recall mo sa ato ang degeneration of cast, makaingon ta na chronic na ni siya and there is extreme urine stasis if naa na to ato ang mga waxy o broadcast. So if naa na gani na sila, chronic na gyud na in nature. Maunang chronic pyelonephritis is also associated with the findings sa kanina mga cast, your granular, waxy, and your broadcast. In contrast sa ato ang acute pyelonephritis na wala siya. So next, other significant finding, we have your urine culture, blood urea nitrogen, creatinine, and creatinine clearance. So let us proceed to the next one. Please write it here, is your acute interstitial nephritis. So your acute interstitial nephritis, AIN, is the allergic inflammation of the renal interstitium in response to certain medications. So there is unsa man na medication, rather ang commonly associated ani niya. So let us write in this one. Here, ato lang isulat diri sa ubos. Mo ni ang medications associated sa ato ang acute interstitial nephritis. So it includes penicillin. Next is methicillin. Next is ampicillin. We also have your cephalosporin. Next is your sulfonamides. We have our NSAIDs. And lastly, your thiazide diuretics. So in your acute interstitial nephritis, there is acute onset of renal dysfunction, often accompanied by your skin rash. So it resolves following discontinuation sa medication and treatment with corticosteroid. Primary urinalysis findings, we have your hematuria, proteinuria, leukocyturia, and WBC cast. So as you can see here, naa siya WBC cast without bacteria. Kay dili man ni siya tungod sa atoang dili ni siya tungod sa bacterial infection, but it is due to your certain medication. So ato ang i-differentiate ang ato ang cystitis, your pyelonephritis, and your acute interstitial nephritis. So here, please copy this table. Magsulat ta diri sa ubos. So we have your upper UTI, pyelonephritis. Lower UTI, ato ang cystitis, and your acute interstitial nephritis. So ato siyang i-differentiate using ani na results. You have your WBC cast, WBC, and bacteria. So i-assess daw nato if nakahinumdum sa discussion a while ago. So ato lang sana siyang i-separate. So sorry if hiwi-hiwi ang ato ang table. Kung ano siya art, style na siya. So sige, with your upper UTI, WBC cast, naa or wala? So naa siya WBC cast. Naa siya WBC and naa siya bacteria. What about sa ato ang lower UTI? Naay WBC cast or wala? Wala, because it is unique to the kidney. Naa siya'y WBC and naa siya'y bacteria. What about your acute interstitial nephritis? Naay WBC cast? Yes, naa. Naa siya'y WBC? Oh, of course. In fact, ang taas ang iyahang eosinophil ani. So, ibutang na to diri, taas iyahang eosinophil. If mag-talk ta about sa atong acute interstitial nephritis. So, what about sa bacteria? Naani siya or wala? Wala. Because, again, it is due to the medications. Dili bacterial infection. So, that is the difference between your upper UTI, your lower UTI, and your acute interstitial nephritis. So next, let us talk about your renal failure. So your renal failure can be acute renal failure, or chronic renal failure. So ang kalahian nila, si acute renal failure kay sudden loss of renal function. On the other hand, si chronic kay there is progressive loss of renal function. Si acute renal failure is frequently reversible, but si chronic renal failure is irreversible and intrinsic renal disease. So your acute renal failure, these are the primary causes of our acute renal failure. You have your pre-renal, renal, and post-renal. In pre-renal, it includes decreased blood pressure, hemorrhage, burns, surgery, and septicemia. For your renal, are acute glomerulonephritis, ATN, acute pyelonephritis, and acute interstitial nephritis. And post-renal kay kaning ato ang mga tumors and your renal calculi. So aside from that, let us also talk about our end-stage renal disease. So mao ni siya ang mga signs or mga symptoms na mahitabo if naay end-stage renal disease. So naay marked decrease in your GFR, mga less than 25 ml per minute na jud. Naa sa steadily rising BUN and creatinine values or naay azotemia. There is electrolyte imbalance and isosteniuric urine, proteinuria, renal glycosuria, and abundant granular, waxy, and broadcast. And mao na siya ato ang ginatawag na telescope urine sediments. So, last topic for this chapter is your renal lithiasis. So, your renal calculi or our kidney stones may form in the calyces and pelvis of the kidney, ureters, and bladder. So, unsa man ni ang procedure using high energy shock waves used to break the stones. Unsay tawag ana niya? That is your, please write, lithotripsy. Next, what are the conditions favoring formation of your renal calculi? So, please write, that is your pH. Next is chemical concentration. And lastly is your urinary stasis. So, ato ni siyang i-run through ang nasa table. So, first is we have your calcium oxalate and calcium phosphate. So, this one is the 75 or comprises the 75% of the renal calculi. It is frequently associated with metabolic calcium and phosphate disorders and occasionally maka-affect sad ang diet. So next one, we have your magnesium ammonium phosphate. Other name ani niya is your struvite. So in your magnesium ammonium phosphate, it is frequently accompanied by urinary infections involving urea splitting bacteria, and the urine pH is greater than 7.0. Oh, ato sa ni siyang i-highlight. Next one is your uric acid. So, ang ato ang uric acid is associated with increased intake of foods with high purine content, and aside from that is with your uromodulin associated kidney disease. So, you have your cysteine, which is seen in conjunction with hereditary disorders of cysteine metabolism. So, that's it for our renal diseases. So in here, we have a table from Branzel, or your third edition. Pwede sad ninyo matanaw dito are the urine sediment findings of your selected diseases. So makita ninyo diha ang mga sa UTI, sa acute glomerulonephritis, sa acute tubular necrosis, o unsa ang ilahang mga sediment findings. So please lang ko, if you can, familiarize or memorize this table because na helpful po ni siya. But if dili kayo ma-memorize ani na table, pwede ra jud if you memorize the concepts or unsay nahitabo mga urinalysis findings kay makorelate ra jud na nato siya ani na table. Kani is just like a simplified form for you to remember or to help you remember. Ina na siya. So, your references, we have your Branzel, your compilation notes, and your Strassinger. So, if you want additional readings or mga dili mo na sabtan, pwede ra pod ka maka-read ana sa Strass or sa kani mga reference books na gihatag. And if you have any other questions or clarifications, you can raise it to me during our rationalization. So, pwede ra ko ninyo i-reach out ana na time. And before we end this lecture or this discussion, I will leave you a quote. So, isa jud ni sa ako ang favorite quote na ako ang ginabalik-balik og hatag. So, again, here is the quote. Forget all the reasons it won't work and believe the one reason that it will. So, since na nata sa second sem, mas dako natong anxiety, mas grabe na ang doubts. Mas mahadlok na ta kay hapit na gyud unta, graduating na jud ta, kanang almost there na gyud kung baga sa ato ang RMT dream. So ayaw kaayo og pasamok ato na mga reasons, ayaw kaayo og padala sa mga kahadlok, padala sa mga doubts. So believe that you can, naabot ka this far, so kaya gyud na nimo. Believe the one reason that it will, believe that one reason na ma-RMT ka. So, manifesting with hard work and prayers. So, highlighter akong nasulat. So, i-erase ni nako. Let us write hashtag RMT. So, makuha ra gyud ninyo siya. So, happy studying everyone, and I hope you learned something from today. Thank you and God bless.